So what is aging? We probably all have an idea of what aging is, but what we know is that it's a dynamic process, right? That's not rocket science, but how we define it and how relevant the definition is for the type of research we do really depends on the perspective. So we can think of aging as the passage of time and reference to time. We can also think of aging as what's happening in the cells as a biological process, or what's happening in the body, the organs and the skeletal, the muscles, the bones, the brain. And we can also think of aging because we often hear, oh, the population is aging or we are aging. We can also look at this from a demographic perspective. And basically what demographic aging means is that when we can observe a shift in the structure of the population, the number of people over a certain age, often we use 65. So when we think about aging, when you say I'm studying aging, it's very important to understand where we locate our research. And when we talk about public health and aging research, the way I see it, is we have to take these different definitions on board in all the project, because there is a passage of time. There's the life course and how we're exposed to all kinds of things that will affect our health in later life. We also need to understand the biology. We need to understand what's not working. And we also have to see what kind of problems are important at the population level so that we focus our energy on the groups or the conditions that are really, a priority, and we don't have the right answer. But very, very simply, the question for all of this research, whether you're looking at the cells, at the gene, or at the bones, is whether or not it's healthy or not healthy. And I'm looking at whether populations are healthy. Of course, populations are made of individuals, but the population, the people in their context of their life, are they healthy? And what can we change for the people themselves, but also the environment around them to make them healthier? So I'll just step back a little bit. When we talk about chronological aging, we often think, oh, I'm 65, I'm past that threshold. It's important to remember or just realize that it is only an administrative threshold. It was 65 was decided at a time where people didn't live very long, well, didn't live as long as today, and where a small proportion of people would live beyond 65, and there was a need to protect these individuals so that they could remain in society. There was some kind of social protection system. What is very fair about the definition of chronological aging is that we all age at the same time chronologically. The other part, in terms of biological aging, we refer really to the changes that happens in the cells, the genes, and how it affects the tissues, the organs. Now that varies a lot from person to person, and we all know that. What we have to look at when we try and do research on biology is what are the things that influence whether a cell will be healthy, whether a body will be healthy later on. And this is what we've looked at. So let's take an example, a very concrete example. I don't do research on bones. I do a lot of research on dementia, and I have an example on dementia. But let's take the bone because it's an easy one, and in a sense, to get your head around of why, from a public health perspective, when we think about studying aging, we need to bring together those different definitions of aging in order to understand and develop policies or interventions that will help us keep all populations healthy as they grow up. So here you have a picture of a bone. You've seen a bone before. On the left, I don't know if you can see my mouse, you have a healthy bone, a younger bone. And later on, if you take a measurement of bone density, how dense the bones are, you'll see that in older people, the bones tend to be more porous with more holes in it. Now, at the population level, what happens, so here you see how dense, so with the y-axis, you see how dense the bones are. When you were young, the bone is being created. Around 30, we have peak density. And after that, the density of your bone decreases, and it varies between men and women. And there are different things that happen in your life, whether you eat well, if you exercise, if you have a healthy weight, if you're exposed to all kinds of things that will determine how much bone you will lose as you get older. So people who do research in aging are interested in bones. The biologists, they will look at the bones and say, why do we lose bone density? People who are interested in population health will say, it's all very nice, that decrease in bone density, but are there people that are more at risk? And here we see that women are more at risk than men of losing their bone density later on. So it's by looking at whole population that we understand where the risk factors are, and if we need to intervene in a different way. Now, in addition to bones, we know also that the muscles don't grow and don't maintain themselves in later life unless we do something about it and unless we work quite hard. So here the picture you see, again, on the left, you have more muscles. You can see the dark red, and you have less muscle, more fat in an older an older arm or a leg. The combination of these two factors, when we think about population, is that it leads to an increased risk of falls. The falls itself, the problem is that the falls link to a lot of hip fractures, and that leads to mortality, more hospitalization, more disability. So the research on aging, because I was asked to talk about what is the scope of research on aging when we think about this topic, is that you have biologists looking at the bones, you may have physiotherapists looking at muscles and different muscle strength programs. You may have people in local authorities, community nurses who are working hard at delivering falls prevention program. And at the population level, there's also people who say, what kind of programs can we implement and that we can afford so that we don't leave anyone behind? There's no such thing as a one-size-fits-all falls prevention program. We have to be able to look at very specific things so that some groups may be left out, whereas others will have more access. Think, for example, if we roll out a falls prevention program in central Cambridge on Sunday morning, well, the people who can join that will not be people who may be living in a rural community who can't drive, and there are no buses to Cambridge on Sunday morning. So some of the things that we think about when we think, how do we make a population healthy and keep their engagement with life and community, we have to think about all these aspects of interventions that are not clinical things, but that are also about how an individual, whether they're healthy or not healthy, can remain engaged and can actually access the services that could keep them healthy or to help them improve. Some of the things, some of you will have seen this diagram before. It's often, it's called the wheel and the determinants of health. And they're also the determinants of healthy aging. We often see, and it's been used a lot when we talk about health inequalities. Why are some people healthier than others? And what are the reasons why that happens? So from the middle, you see it can be your age, it can be your sex, it can be your genes, but it's also your lifestyle, if you smoke, if you don't smoke, if you live in a community that has a social network, and so on. So all these boxes that you see are the things that will influence your risk and your ability to maintain your health as you grow older. Now, that concept of life course is a bit technical, but I think it's quite an important one. The work we do in public health and aging is we're trying to understand risk factors from a life course. There's a lot of people who are interested in what are the things we need to do when we have small children. What do we do in midlife? What can we do when someone is retiring? Because it's a critical stage in people's life where behaviors might change. So the life course perspective on aging accounts for the different factors that will shape your life over your life course. And what is the complex thing and what is often difficult and why we say, well, we don't quite know what to do, is that these risk factors will be independent. So let's say you smoke, you're more likely to be unhealthy later on, cancer, dementia, things like that. These risk factors are cumulative, so it means the more you expose, the worse the impact on your body. And they also interact. So if you smoke and you happen to be in a condition, a socioeconomic environment, so in a neighborhood with very little assets, or if you didn't have a chance to have an education for any reason, these things interact and puts you more at risk of not being healthy as you grow older. So you could look at individuals and their risk factors, trying to change them. And that's what we do in public health. And a lot of people who do prevention works that. But thinking about the pyramid, the age pyramid and demographic aging, we have to look at this across generations. Because some of these big factors that you see around, the work environment, the education, whether or not we have good housing policies, will take a long time to impact the health of a population. So the life course is relevant in terms of both what we look at in relation to time when someone's old or someone's young, but also at what time can we change the risk factors. And there's a lot of things about those relationships that we don't understand. I won't read this slide, but it's just a list of things that when we ask people what might happen when you get older, and what is it that is a problem for you or a concern, all these kinds of things come up. And when we think about clinical research, a lot of research that is done in what I call a biomedical model, these are often the things that we see, and it's often talked about in a deficit way. So we lose vision, we don't eat enough, we can't be independent. In the work I do, which is broader than just looking at individual and the body and the cells, there's a whole range of other factors that we have to consider for healthy aging and what it means to people to actually be optimal. And that means social isolation and lack of social support, financial challenges due to retirement or reduced income. If you're used to engaging in a community because you can drive or you can have a membership at a gym or whatever it is that you do, and if suddenly these conditions change for all kinds of reasons, that creates another barrier for you to do the things you need to do to remain active and healthy. Age discrimination in employment, you have to retire because the policy says you have to retire. Increased vulnerability to abuse in some contexts, some settings, often more hidden than we want to recognize. Interaction between medication, change in intimacy issues, loss of loved ones, grief, ageism, challenges in accessing appropriate healthcare. So when we think about the determinants of healthy aging, they go beyond looking at the body and how it works from a biomedical point of view. We have to be very aware of the relationship of that body with the environment, whether it's the physical environment. Do you have to go up do you have to go up the stairs to get to your bed? Do you have access to the internet in order to join that remote GP appointment as a follow-up of a fall? So these are the parameters that will determine your ability to remain healthy. So just an example of risk factor for dementia, for example, just to make this a little bit more concrete. What we have here is a diagram of a Lancet Commission, basically looked at all that we know from the scientific evidence, all the studies, to see how much can we actually reduce the number of people who have dementia. If we were able to deal with the risk that we know, how would we do that? But more importantly, how much of the dementia that is occurring in generation can we decrease? How can we modify this? So there's a life course influence. So that shows the life cycle model. For example, if you look at the top, we have, well, we know we have non-modifiable risk factors, so things you can change. If you're born in 1950, well, then you're born in 1950, you are a certain age, you were exposed to things in that generation that there's not much we can do about. Family history, genetics, but there's also all the modifiable ones and all the things that are not managed that could be managed, like hypertension. So if we look at the top one, you have less education. So we know that these data, these are all models, and they're not, you don't look at the exact number and say this is actually 7%. It's just to give you a range of what is in the realm of the possible in terms of decreasing dementia risk. So we could decrease dementia risk by around 7% if we improved education in young children. If we dealt with hearing loss, hypertension, consumption of alcohol, and obesity in midlife, we could decrease, and you can see the proportion, we could further decrease the risk of having dementia as people get older. And you can see the other ones in purple: smoking, dealing with depression, social isolation. So these are all risk factors that we have evidence of the relationship at this stage in life with the risk of having dementia after 65. So some of these studies were done with 65 as a threshold. So these are just examples of what we look at. And when we study aging, this is an example of dementia. But if you take frailty, for instance, there's a lot of work around frailty, which is a syndrome of increased vulnerability to, you could look at all these risk factors as well. So this is a way of thinking about the research on dementia. Some people focus on specific, they're specialists on dementia and social isolation. Other people are a little bit more generic. I call myself a bit generic because I'm interested in a lot of these factors and how we can intervene. So we've talked about the journey. This will determine whether you are a super ager, that's like this on this picture, whether you have maybe some problems, but still connected with a network and or have mobility issues or not. But it's also important to consider whether or not you live in an environment or society that will create artificial divides in a way in your ability to engage. So my research, I've described it in a way, but more specifically, and maybe to make it more concrete, and how we engage with the public. Again, the public, there are many publics that we engage in our research, from thinking about what the problems are all the way to making sure that how we report back our studies are actually relevant and communicated the right way. The hypothesis and the starting point, I'm a half full. So, either you see a glass half full or half empty. I tend to see it half full. So I take a positive spin on aging. And my work is based on the idea that promoting healthy, engaged, and active later life can work and add value to people and to society, irrespective of whether or not you're healthy now or you already have some issues. If we target these interventions to the right people, and if we really take an equity lens, so make sure that we don't create inequalities in access when we do that. And for that, I have a multidisciplinary team of people, researchers, sociologists, demographer. I have a background in economics as well. And we bring these different perspectives to think about what can we do to create those environments where people can have a healthy life. So that means understanding the factors that influence healthy aging, and we have projects on that. Developing interventions, so testing, like trials and things, to test intervention that are tailored to needs. And here, a big focus of our work is on making sure that we reach out and we identify people at higher risk, including a lot of people who tend not to engage with research at the moment. So we don't ask people to come to us. We often go to communities and we engage with communities, different faith group, for instance. We have interpreters if we need to engage with communities who may not have English as their first language and things like that. And demonstrating what works and adds value. And that is a big part of my work on evaluation. So looking at really collecting data to see, does this work? How much does it cost? Does it work for everybody? And if not, why not? That research can be done with individuals. So let's say I'm interested in a physical activity intervention. We often work with what I call dyads or groups, especially for research in dementia, and also in people and in research on frailty, because often we need a carer, a loved one, someone who supports the person with dementia to facilitate the engagement with research. So we don't work just with carers, we also work with the people with dementia, and develop different approaches to make this accessible. We also work with different networks, so communities, a particular community. Let's say we had a project looking at what makes growing old in a rural village possible nowadays in England. And we work with cities, and that's what is probably quite, I think, might be quite different from what you usually do, is when you look at age-friendly communities. So that's the core of my work. This particular image shows the multi-dimension of the work. So healthy aging is driven by a good fit between an individual and their environment. Whether we talk about the physical environment, can you walk to go to the shop? The social engagement, the social environment. Do you feel stigmatized if you join a yoga class, for instance? Or economic as well, the economic environment. Do you live in an environment, or do you have the types of economic support to make sure that you have access to what you need? And that wheel of 8 domains was promoted and is pushed by the World Health Organization from a survey across the world of having a conversation with older people to say, what is it that stops you from remaining healthy? And these different domains, so in England, we have, I think now 54, 55, in the UK, a network of 55 age-friendly communities where there's a political commitment to changing these infrastructures to facilitate engagement with daily life as people get older. So one important thing here, it says age-friendly, but we really think about aging-friendly. So thinking about the process and the dynamic. You can be perfectly okay today, and if something happens next week and you break a hip, I hope not, obviously, then suddenly the environment might not be as age-friendly for you because you have now a number of challenges to engage with the environment around you. So an age-friendly community approach is one where we remove the physical, social barriers and implement policy system technologies, social structures that would allow and help people to do the things they value. So that is quite critical. And this is where the conversation with older people, carers, the public is central to our work, because I am not at all placed to decide what people value. And that varies according to experience, culture, and all the things we've talked before. So the model that we follow for our research is to talk with different communities and ask the question, what makes a place aging friendly? So we ask people what is important to them. So in a nutshell, the outcomes is that they want to remain physically, mentally healthy, but also engaged, feel independent, feel that they are safe in the community, also feel that they have people that they can talk to. And also a lot of people say, I need a place where I can feel that I have a sense of purpose, a sense of that we value. So this is the work we do through interviews, surveys, and things like that. We also look at what works and does the work have an impact? So that means we look at what we already know. So our work builds on the shoulders of giants, really. And what we know about age-friendly communities is that there's very little evidence. We know how to set them up. There's a lot of good example of how do you set up a community and a group of partners that will work towards changing things. What we don't know is whether it actually makes a difference to the life of older people. And one of the reasons we don't have a lot of evidence in that is because these are quite complex things to evaluate. And the people on the ground, whether it's in the local authorities, the Dementia Alliance, often they don't have the capacity. So it takes a lot of time. So there's not a lot of resource, but also it means using a toolbox that can be quite complex. So if you need to measure how much it costs to run a dementia cafe, you could do your budget, but there are a number of things that need to be considered to see, can we sustain the dementia cafe every week? So there's a number of tools that we need to understand in order to say, can we sustain a dementia-friendly community, for instance? How does it work? Who does it work for? And how are we excluding people by, for instance, in a dementia cafe? That assumes that people with dementia will actually be able to come to the cafe. But what about all the people with dementia who don't have the possibility of actually getting in the central of the, going to the center of the village twice a month in order to have good conversation with the neighbors. So an age-friendly community with dementia-friendly community, as an example, would say, where are the people with dementia in our village? And can we make sure that we get someone to reach to them and bring them in, or provide other types of support for them if they have to stay at home? So these are all they sound like practical issues, but these are difficult to nail down to see how do we do this well and make sure that it's equitable. So that's the work I do. Here is just an example. We can't do this with one project. So what I've described here is just a combination of different projects working with different communities, sometimes cities, sometimes rural communities, but we always have the same overarching question. What can we do to make this place age-friendly? We involve the public at different stage. So we have people who engage in framing the research, and there are different people than the ones we survey. The participants in our, let's say, the equivalent of a trial are different than the people, and they are with us on a journey. So we had a number of groups that stayed with us for many, many years. COVID actually cut our flow. Now we're finding hard to re-engage in the same way, and maybe you'll have views on how we can improve that and what works for you. That would help me actually improve how we engage with different people who don't necessarily engage super easily with some of the work that we do. We give them different tasks, and we have different scales of involvement, meaning sometimes we have one-on-one, sometimes we have focus group. Often we just go and join a community event and go to a bake sale and talk to people about why they come and why it's important. And what is quite fun and not challenging, but quite stimulating is the fact that we often have varied perspective. So the people we engage, sometimes they will say, I'm a patient. Sometimes I'll say I'm a carer. Sometimes I'll say I'm a member of a rural community. Sometimes they say I'm an older person, but I don't feel like one. Most of the time, people come in those community events or in the room here in Cambridge or on focus group online, wearing all these hats. And in a way, this is the type of perspective that we need in the type of work that I do to really capture the complexity of how do we live better life as we get older.